It's my pleasure to introduce Dr. Michael DeBernardi. Dr. Bernardi is a clinical and prescribing psychologist, and for over 5 years has been the Chief Executive Officer at the LifeLink. If you're not familiar with the LifeLink is a major provider of mental health, substance abuse, human trafficking aftercare, housing, and a multitude of other services for homeless and indigent citizens in the greater Santa Fe area. LifeLink's been around for actually over 30 years. I'm on the board. We have about 55 employees and have a very robust program in the areas I mentioned. Michael received degrees from the University of California at Berkeley, the Chicago School of Professional Psychology, and New Mexico State University, and has worked in a variety of inpatient and outpatient mental health and substance abuse settings over the past 30 years. Dr. DeBernardi also serves on the board of advisors for the National Association of Cognitive Behavioral Therapists and has co-authored numerous articles and a book on the subject. And with that, it's my pleasure to introduce Michael DeBernardi. Thank you so much, Michael.
Thank you, Craig. Thanks for having me. Thank you to NAMI for having me. It's exciting for me to do this talk without, too much self-disclosure. I'll say that it's really 40 years ago experiences with psychedelics that led me into this field. I would not be a psychologist had I not had some early experiences where I recognize that, wow, there's a lot going on in our heads. There's a lot going on in our minds, and not only the things that we're used to, but some other things that I'm not used to at this age. So it led me in this direction. And, one of the things I'll say is that I always kind of had a professional fantasy, I guess, of someday being to the point where we could offer treatment in this area, these medicines to people suffering from mental illness. And I really never thought that it would come during the course of my lifetime, the course of my career, but it has come and it is here. And so we are really on the cusp of what I see as a revolution in clinical care, psychiatric care. And so I'm excited to share this with you. I do have a lot of information to get through. As always, my presentation is way longer than it was supposed to be. So I'll make my best effort to get through it quickly. I'll try to finish about 6:45 for questions, but I'll also stick around after that till about 7:15 if people have other questions they want to address. So let's go ahead and get started.
And I'll just butt in here real quickly, Michael. And if you happen to have a question and you'd like to go ahead and put it in the chat along the way, we probably won't have Michael deal with it until afterwards. But if you think of a question you'd like to ask, feel free to put it in the chat, and we'll get to it after Michael's presentation. Thank you, everyone.
So yeah, as Craig mentioned, I'm with LifeLink. I've been CEO for 5 years, but I've been at the agency for 20 years. This summer, I was a clinical director for the first 15 years. And then the founder, Carol Luna Anderson, who founded the organization in 1987, stepped down, and I stepped into the role. So just real quick, want to go over some of our programs. What drew me to LifeLink was the fact that the organization does so much under one roof. I really saw it as a kind of a one-stop shop in Santa Fe. And so just, real quickly to kind of show you some of the things we do. We started actually as a housing program, as a homeless shelter in the early days, and still housing is a major part of what we do. We're the second largest supported housing provider in New Mexico. Offering short-term rental assistance, vouchers, intermediate, permanent supportive housing, all kinds of support, homelessness outreach, and the safe outdoor space that just opened in Santa Fe. We are the service provider for that. So we do behavioral health care, individual, group, family therapy, psychiatric care, medication-assisted treatment for opiate use disorders. Everything we do is trauma-informed in terms of the organization. We have trauma-specific services in terms of groups and EMDR therapy and those kind of things. recovery happens best when you're not only receiving the treatment, but you are getting support services wrapped around that. So again, we offer a full spectrum of that. Peer support services. I believe that almost a third of our staff are certified peer support workers, so it's a major part of what we do. We offer comprehensive community support services, which is case management. We have a psychosocial rehabilitation program, clubhouse, supported employment, navigation referral, etc. And then for about the last 15 years, we've had a human trafficking aftercare program that really is recognized as one of the top in the country. We've been funded by the U.S. Department of Justice since 2015. We run the state human trafficking hotline, and this is really working with victims who are coming out of situations. So frequently we get a call from law enforcement saying we rescued this person from this situation or that, and we work with them on that. So we do a little bit of everything. The only thing we really don't do is medical care, but we partner well with La Familia, Southwest Cares, and other organizations in the community to make sure that our clients are getting services there. So that's the lifelink in a very quick nutshell. But you're here to hear about psychedelic science and therapy, so let's move into that. I like this quote: psychedelics are to the study of the mind what the microscope is to biology and the telescope is to astronomy. David Nichols is a very famous psychedelic researcher. And I think that we really have seen that psychedelics are giving us a glimpse into, like I said, I had 40 years ago, into what's going on in the mind, but offering us ways to help work with things that may go wrong in the mind. And we're going to get into a lot of the research around that. So mind-altering substances have been around forever in human history. Nearly every culture has seemed to use something for healing or spiritual purposes, but it's really been the last 20 years. There's been a huge explosion in research, clinical trials, looking especially at the safety and efficacy of psychedelics, as well as looking at it for treating a wide range of mental health and substance use disorders. So far, and we'll talk about some of the different psychedelics, not all of them, because there are many, but we've seen very promising research for treatment of depression, anxiety, PTSD, addiction, and other things. And because we're in the era of high-tech brain scans, we can really see in real time when someone is on a psychedelic, what's going on in the brain. And then combining that with clinical protocols, I'll talk about that more later, we're seeing very rapid and lasting changes happening for many people in these clinical trials, far better than the medications and the treatments we have. So that's why this is so exciting, because it's almost revolutionary in that we're seeing ways to treat things that seem to happen very quickly and very profoundly. While it is very promising, it is a very complex arena with a controversial history. Legalities still need to get worked out. We're not certain about what it really works for. And so really, in short, we're still under scientific evaluation. It's coming very soon, legal psychedelic therapies, but at this point, things are still illegal at the federal level and state levels. And so we need to consider all of that when we're doing our work. Disclaimer right off the bat: I am not condoning or advocating for use of any illegal substance or the use outside of a controlled clinical environment. Psychedelic drugs are very powerful, and they can lead to significant psychological distress if they're used in a manner that's not safe or in accordance with research-informed clinical protocols. So I'm not encouraging you to go, tripping in the woods this weekend necessarily. What I'm talking about here is things that have been studied and that science has shown to be either very promising or effective. So, brief psychedelic history. They've been used for thousands of years, I mentioned, in spiritual and healing purposes. This is a map I found online that shows all of these little mushrooms are places in the world where there is evidence that they were using mind-altering substances at some point historically. So as you see, it pretty much covers every continent. It's like Antarctic is not on there, but used a lot. So this is not something new. These are things that have a long, rich traditional history that science kind of started to catch up with in the early 20th century. So in the late 19th century, Western scientists started looking at these plants and traveling to these locations to see what was happening there and to see if they could figure out, using our science, what was making the difference in the healing with these substances. The first one we really saw, the first big one, was LSD. That was discovered in 1938. The psychoactive effects of LSD were discovered in 1943. In fact, coming up on April 19th is what we call Bicycle Day. So Albert Hoffman, the person who discovered LSD, accidentally had some in contact with his skin. And as he left his laboratory in Switzerland and started riding home, things started to get very strange around him. And that was where he first discovered that, wow, he was looking for some other medical purpose and started to see that there's something going on psychoactively here, which led to a lot of research over the next 20 to 30 years. LSD was the
Mi-
first.
Michael, if I could butt in real quickly,
Sure.
Jessica had to shut down her computer, so if you could make me a co-host, just go up to my little box and make me a co-host, and I can let people in who may still be in the waiting room.
Okay, I've let the people in who are in there right now.
Oh, well, good for you. You're hired.
Um, Good. Yeah, I can't see how to make you a co-host, but I'll
Okay.
let people as they
All
show
right.
up.
Thanks a lot, Michael. That'll
Sure.
work.
So
That'll
early
work.
LSD research, 50s and 60s, there were hundreds of researchers doing this worldwide. And actually, they did about 40,000 patients were treated with LSD, 1,000 clinical papers. There were 6 actual clinical trials looking at it, specifically for alcoholism. That was the first place they started and found out that it was having very profound effects with that. In fact, the effect size, if you look back at those clinical trials, were actually better, equal to or better than all current therapies we're using to treat alcohol abuse disorder. So it was very powerful. There's been a couple meta-analyses done, looking at a 9,000 subjects, 75,000 sessions, minimal adverse reactions. There was one attempted suicide and 2 completed suicide out of those 9,000 patients. And Masters in Houston in 71, in a meta-analysis, found that the results were overwhelmingly positive and describing safe and effective treatment. So there was really a lot of push in the 50s and 60s for looking at LSD, but politics got in the way. Interesting sidelight that I always like to show here. Here's a quote. I'm certain that my LSD experiences helped me very much. I find myself with a heightened color perception and appreciation of beauty almost destroyed by my years of depression. The sensation that the partition between here and there has become very thin is constantly with me. And that is from Bill Wilson, who many of you might recognize as the founder of Alcoholics Anonymous. And he actually early on in the AA days advocated for LSD treatment to be a part of the AA recovery program. Some of his colleagues at the time kind of talked him out of that, but I always found it very profound that really one of the biggest names in alcohol recovery credited LSD with being a major part of his own personal recovery from it. Having keyboard issues. Okay, so back to here. I mentioned politics got in the way. Nixon administration, 1970, Controlled Substances Act. We're going to make everything illegal. And that kind of flowed into the 80s, the war on drugs. That's when I was growing up. I remember Nancy Reagan and her just say no attitude. And so when they created the Controlled Substances Act, they found a way to schedule drugs based on what they considered dangerousness. And this is, whoops, and this is still what we use today. So I won't spend a lot of time on this, but there are different levels of schedule, and these are only for scheduled drugs. There are many medications that aren't on the schedule at all. But as you see, Schedule 1, which is considered the most severe, are drugs that are classified as having a high potential for abuse and no accepted medical use and are not safe to use under medical supervision. Here we see marijuana, LSD, ecstasy, and heroin. We'll talk about LSD and ecstasy later on, but the research is showing that's just not the case. And certainly with marijuana, with cannabis, we've reached the point now where more states in this country have legalized it than not, including many with medical programs. So I know that the president has asked the DEA to review the scheduling around cannabis, but as these psychedelic drugs get further research, further along in the process, we should be seeing them rescheduled as well. I do want to point you to Schedule 3. We see ketamine. I'm going to talk about ketamine. That is one now that is kind of legal for treatment, and so we'll talk about that. But really, they're calling these drugs dangerous when, honestly, as we'll see, the research does not necessarily bear out. So I mentioned this was political. I love this quote from Terence McKenna. Psychedelics are illegal not because a loving government is concerned that you may jump out of a third-story window. They're illegal because they dissolve opinion structures and culturally laid down models of behavior and information processing. They open you up to the possibility that everything you know is wrong. And when substances around it now, it was very clear that it was the Nixon administration's efforts to stop what was going on around Vietnam War protests, et cetera. The young folks in those days, the hippies, et cetera, were using a lot of psychedelics, fighting against what was going on in Vietnam. Minority groups were using cannabis and other drugs, and the Nixon administration said, let's just shut this whole thing down now. Anyway, that's what Terence McKenna thought was going on, and I think he was a wise man in many ways, so I wouldn't argue with this one either. So coming then to MDMA, also known as ecstasy or Molly, we'll talk a lot about that. It was being used on the underground in the 70s and 80s for therapeutic purposes. A lot of therapists were seeing, hey, this is helping people open up, talk about things that were difficult for them, but it was illegal. And in 1985, I believe it was, got added, specifically made illegal, and they shut it down. So even the underground MDMA therapists were not able to utilize it anymore. In the early 80s, though, MAPS, the Multidisciplinary Association for Psychedelic Studies, decided, you know what, we think there's some potential here. We're going to work with the FDA on figuring out how to make this work. And MAPS really is heroic in this regard. And have now completed 2 phase 3 clinical studies. We'll talk about that, showing the effects and potential of psychedelics. What we've seen the last 20 years or so is an explosion in research, and we're going to go through some of that, showing some real promise for mental health related disorders. So when I talk, and I apologize, I'm talking fast, I got a lot to get through. When we're talking about psychedelic therapy, it involves a controlled use of hallucinogenic drugs, and this is really important, so why it's highlighted as part of a treatment plan for mental health conditions such as depression or PTSD in clinical trials or setting. Certainly for millennia, people have used psychedelics recreationally, but what I'm talking about tonight is use in research or treatment setting. The safety and efficacy of these drugs is being established as we speak through designed and vetted treatment protocols, and should only be used within those framework. And people who are prescribed psychedelic therapies should always be clinically monitored and not try to take the drugs on their own. So again, another disclaimer here. Quickly, just kind of an overview. These are some of the promising research studies that have been done, different areas, depression, end-of-life distress, PTSD, substance use, social anxiety and eating disorders, and then even things like chronic pain, fibromyalgia, Alzheimer's, autism, etc. These are all research studies, and here's references on a lot of those that have shown some real promise in it. So this is not just 1 or 2 things happening. A lot of people are seeing that these are something that we should be paying a little more attention to. I mentioned the clinical trials. I'm going to go through this really quickly. Any drug that's approved in the United States needs to go through a series of studies, phase 1 through phase 4. Each one looking at, numbers of patients. What are we looking at? Or how safe is the drug to take? How well does it work on people who have the disorder we're looking at? Phase 3 is usually the final stage of research, and they look at hundreds to thousands of people who have a disease and are trying to see how effective it is. Phase 3 is the last phase before drugs are approved by the FDA. So people will apply based on positive phase 3 results and then move into phase 4, which is just over the course of time, continuing to look at drugs, seeing what works. And the reason I talk about this, because we do have some psychedelic drugs in phase 3 right now, and some that have already gone beyond that and are currently applied for full legalization. Another thing around scheduling and research is that the FDA has something called breakthrough therapy status. And breakthrough status means we're looking at drugs that are intended to treat a serious condition, and preliminary evidence shows that it demonstrates substantial improvement over available therapy on a clinically significant endpoint. So what they're saying is these drugs are showing better outcomes than the drugs we have now, so we need to prioritize them and look at the research. At this point, 3 psychedelic compounds have achieved that: ketamine for treatment-resistant depression and major depressive disorder with risk of suicide, MDMA for PTSD, and psilocybin for treatment-resistant depression and major depression. So even the government, who may or may not have had ulterior motives for making these things illegal, is saying that these drugs are showing such promise that we've got to fast track getting them through the approval process. Though another quote I found, so FDA approval, for example, of MDMA is just step one. What do you do when you've got a medicine that's now approved by doctors, but they're afraid to recommend it or prescribe it because it came out of nowhere? They're like, whoa, psychedelics are Schedule 1, extremely dangerous. Don't do drugs. Just say no. Now I'm supposed to be giving it to a patient. That's a barrier. That is a barrier. There are a lot of people who've been working in the medical and mental health field for many years who've been taught that drugs are bad. And so we're facing now having to re-educate people, get people on board with maybe looking at the potential of these substances. There are certainly risks and cautions. Legal, as I said, these things are legal, not everywhere. I'll talk about it later. Safety guidelines. We really haven't established long-term safety data on a lot of these. And even though they seem to work very well in therapeutic settings, what happens when people take them out of there? Substances may be laced with other things. If you're buying these drugs off the street, you don't know what you're getting, versus research studies where you do know what you're getting. Potential for misuse, certainly. We've all heard parties and those kind of things that are happening with these drugs. And then psychological vulnerability. Certain underlying mental health conditions people with those conditions should not necessarily be playing around with psychedelics because it may actually exacerbate symptoms. This is a very pretty graph. That's why I chose it. That shows some studies that were done in New Zealand, replicated in Australia, and then in other countries as well, looking at harm of drugs, of different drugs. And over on the top right, you see drug-specific mortality, drug-related mortality, dependence, loss of relationships, injury, crime, etc. So they looked at the harm of drugs in society in all these areas and then ranked them in terms of problematic challenges with them. And as you see, alcohol is by far the worst, methamphetamine, tobacco, et cetera, as you go down. The drugs we're talking about tonight, ketamine, MDMA, hallucinogens, are very low toward the end. So even though there was all of this talk in the 60s about it damages your DNA and people jump off buildings and kill themselves, et cetera, actually doing research into it shows that these drugs are among the least harmful of any illegal drugs that are out there. Some of the common side effects: altered sense of time, anxiety, fear, increased heart rate, blood pressure, headaches, nausea, etc. They're not always pleasant to be on. Very important, the pink bullet there: history of bipolar manic episodes, psychotic episodes, schizophrenia, paranoid traits, or family history of schizophrenia may disqualify you for treatment, as the compound may be destabilizing. If you meet the criteria for any of those, have that family history, odds are you're not going to be in a clinical trial, not because these drugs cause schizophrenia, cause bipolar disorder, but rather if you have a predisposition to that, it may exacerbate your symptoms. So very important, especially with a NAMI audience, to recognize that, if you or family members have these things, these are not medications to be playing around with. While the classic psychedelics really have negligible toxicity or dependence risk, the psychological risks are what we need to really understand. Some opportunities here. Stan Grof, who's really one of the giants in the field, was doing research in Czechoslovakia in the 50s and 60s and came to America, said after working with these subs for 50 years, 4,000 sessions, I've developed great awe and respect for these compounds and their potential, positive and negative. They're positive tools, powerful tools that can be used skillfully, ineptly, or destructively, resulting, the result will be critically dependent on set and setting. Although many of us think of psychedelic drugs as dangerous drugs, it's time for a rethink. They are non-toxic, non-addictive, actually have very few side effects, even compared to legal drugs, and could potentially offer relief from people suffering from a wide range of symptoms. And then a meta-analysis from 2013 concluded that classic psychedelics like LSD, psilocybin, mescaline do not cause brain damage, are not addictive, and do correlate with lower mental health problems. So there is promise here. All right, I'm going to talk about three substances today, just in very generally, because they are the three that are either legal at this point or very close to legalization. Ketamine being the first. Synthesized in 1962 as an anesthetic, works on the brain, the glutamate receptors, which play a key role in learning, emotion, etc. Um, haven't been a ton of large sample size research done, but it's showing that off-label ketamine use is on the rise for treatment-resistant depression and suicidal ideation. There are ketamine clinics all over the country, including 3, 4, 5 in Santa Fe, where you can go if you're depressed and get ketamine. But I will say that that is all off-label. It is not approved for, especially injectable ketamine, like is being used at these clinic for treatment of mental health, although there is one form that is being used that way. They are quick acting, but they require continuing treatment. So usually people on ketamine go through, every few months we'll go through another session. There is some caution around them for addiction with self-administration. Ketamine really blew up as a party drug in the 80s and 90s at raves. And so much better to be done in a controlled clinical setting. And it is currently registered in numerous phase 3 clinical trials for conditions including depression, substance use, and chronic pain. I mentioned the one that is legal. It is S-ketamine. It's the only FDA-approved psychedelic. It's a nasal spray for adults with treatment-resistant depression or depression with suicidal ideation. Research shows significant decrease in depression after 4 weeks of treatment. And after 4 years of treatment, the symptom improvement is maintained with 46% of patients in remission from, and this is severe treatment-resistant depression, meaning people who've tried 2 or more different medications or treatments with no response. So about half of those people after 4 years are seeing major improvement from ketamine, which is much better than any other drugs we have. Like I mentioned, hundreds of ketamine clinics have opened around the country using IV ketamine infusions. A couple different studies I mentioned here. One from 2022 showed that 50% showed clinically significant improvement in symptoms, 30% full remission. With people with suicidal thoughts, 73% had significant decrease in the symptoms, though about 8% reported worse depression and 6% increased suicidal thoughts and behavior. So even in these very positive clinical trials, you're seeing that for some people, it doesn't work as well and actually may be counterproductive. So again, a reason why you should be using it in a clinical setting where you can get other support around you rather than just kind of doing it on your own. Second one, MDMA. Methylene dioxymethamphetamine. So you'll notice that methamphetamine there. MDMA is part of the same thing as methamphetamine, part of the same class as those drugs. MDMA, commonly known as ecstasy or Molly. It was first synthesized in 1912 as a medication to control bleeding. It works on serotonin, dopamine, and norepinephrine. Neurotransmitters as well as the brain areas working with memory, emotional arousal. They call this drug either an empathogen or an entactogen, as its effects include enhancement of empathy and emotional openness. If you remember, this is the one I was saying was being used underground in the 80s. Because if you're in therapy and you have extra emotional openness and empathy, odds are you're going to engage a little deeper in the therapy. Experiences with MDMA involve euphoria, heightened empathic connections, increased energy, heightened sensory perceptions, and an embodied trust of a sense of trust and safety, which, of course, again, if you're in therapy, to be able to feel safe and to trust makes a big difference in terms of how you'll be able to respond to treatment. I did mention it became Schedule 1 in 1985. What's really amazing about MDMA is it's been researched along with the development of very sophisticated treatment protocols that have really become the gold standard for psychedelic assisted therapy. These drugs are not just given and sending people home. They are part of a treatment protocol, a treatment model, and I'll show you a slide on that in a minute. But the MDMA has really become the gold standard. They've trained thousands of clinicians. I went through the training in 2021, and it really is kind of the gold standard of receiving any psychedelic treatment. At this point, there have been 2 phase 3 studies completed. Their application for legalization is under review, and it's likely to come this year, probably 24, 25. The clinical trials have looked at more than 800 individuals. Again, these are people with severe chronic PTSD, people who military PTSD, severe accidents where they've watched people die, et cetera. So these were not just, people who got into a fist fight or something and had nightmares about it, but severe PTSD who had not responded to previous treatments, and they'd been suffering for an average of 14 years. The results, the reason this was fast tracked, the reason it will be legal soon, is that the first phase 3 trial, second phase 3 trial confirmed it, recently published, show the following 3 medicinal doses along with the psychotherapy, 88% of those patients experienced a clinically meaningful reduction in symptoms. 83 no longer met the criteria for PTSD 2 months after treatment, and 67 no longer met criteria 1 year following treatment. So these are amazing results. These are far better than any PTSD treatment we have. PTSD has notoriously been one of the hardest illnesses to treat. And what these results are showing that 2/3 of people no longer have PTSD even a year after going through
Wow.
these sessions. So really amazing results. I
Michael,
mentioned,
just to
yeah.
hop in here real quickly, we've got about 10 or 11 minutes for your presentation. And to let the audience know, because we lost about 10 minutes for the technical difficulties, we'll be going on till about 7:15. But if you need to leave at 7 when we normally end, feel free to. But Michael's agreed to stay on till 7:15. And so we'll wrap the forum up at that time. Thanks, Michael.
Thank you, Craig. And I think at this pace, I know I'm talking fast, but I'll probably get through it all by then. So,
Sounds good.
so I mentioned MAPS, Multidisciplinary Association for Psychedelic Studies, a nonprofit. They really have been the pioneer in all of this. They're the ones who in the 80s petitioned the FDA to start doing research. Rick Doblin was the founder. He's still part of the group. They've done fantastic work, and they really deserve all the credit for the fact that MDMA will be legal soon. They sponsor a psychedelic science conference every few years. It happened last summer in Denver. There were 15,000 people from all over the world showed up for this, talking about research. I had the good opportunity to go, and it was absolutely fantastic. The next one is scheduled for summer of 25 in Denver again. They're expecting close to 25,000 for it. So if you have any interest, I encourage you to start making plans now. By far the best conference I've ever been at. And I didn't even take any psychedelics. It was just amazing. Okay, so MAPS is kind of the ones behind it. And this is what their protocol looks like. So starting up at the top left, we screen people who meet the criteria, we enroll them, and this is both the research and the treatment studies. So after someone is enrolled in this treatment, there's 3 preparatory sessions, and these are done to explore, again, this is around PTSD primarily. What's the nature of the trauma? What would you like to work on? Get some history, etc., much like any therapy experience would be. Following that, there is a single MDMA therapy session, 8 hours. The person is given MDMA. They're blindfolded. I won't say blindfolded because that makes it sound a little traumatic, but eye coverings, music is a part of it. They are, for the most part, on their own during this, but you have two therapists in the room, a male and a female, who, once the person kind of, emerges from the music or whatever, might have some things to say, then they do some processing around it. So it's mostly self-driven, but there are therapists there to support the process. And there are two therapists there for safety protocols. You know, they talked in the 80s about MDMA being the hug drug, the love drug. And so, of course, liability, you don't want people feeling, randy or whatever and making accusations. So safety is built into it. So, and following the initial session, there are 3 integration sessions. Integration is very important. That means taking the lessons that were learned, the experiences that were had in the session, and starting to do some therapy around them to make sense of them. So you have 3 of those sessions, another MDMA session, 3 more of those sessions, a final MDMA session, and 3 more final integration sessions. So overall, once someone's enrolled in the study, it looks like you're getting 12, 13, 14, 15 sessions total. So, and these are generally done on a kind of a weekly basis. So this is about a 4-month treatment protocol. And again, the earlier slide saying a year post this protocol, 2/3 no longer met criteria for PTSD. So again, just demonstrating this isn't just handing someone a pill and saying, take it and have fun. These are very structured. And having been through the certification training myself, I will say there is a lot that goes into it, a lot of preparation, a lot of learning for those clinicians wanting to do this work. MDMA is the one I mentioned that has the gold standard, but the psilocybin trials, the ketamine trials are also using similar. What has happened though with ketamine is that has rolled out in communities, in clinics. Many of them are simply giving the substance. It lasts about an hour. The person is left alone. They kind of deal with it and they go home. So there's not as much integration, preparation, et cetera, being done around it. There are some studies right now looking at that model versus a more structured model. So we'll see. Certainly in this presentation, I'm advocating that as this rolls out, we need these structured clinical models. It's not just giving someone a drug and saying good luck with it. So final drug we'll talk about is psilocybin. This is the active ingredient in hallucinogenic mushrooms, shrooms. We have seen evidence of the use of mushrooms 4,000 years BCE, so over 6,000 years ago. Many cultures have used these, even like the Scandinavian cultures, Finland, etc. There were hallucinogenic mushrooms above the Arctic Circle, and actually reindeer would eat the mushrooms, and the people would follow the reindeer around, capture their urine, and then drink their urine. So people have used these things in all kinds of seemingly strange ways for thousands of years. In the 50s, they finally isolated the active ingredients, psilocin and psilocybin. Again, this is a serotonin substance, acts on the serotonin 5-HT2A receptor. Subjective experience alterations in visual imagery, sensory synesthesia, meaning senses seem to mix a little bit. So you smell colors, you taste sounds, etc. Feelings of expansiveness, ego dissolution, mystical experiences, feeling one with the universe, transcendent, etc. Psilocybin was part of the Controlled Substance Act, again, Schedule 1 in the early 70s, but in 2000, Johns Hopkins University started doing some research. I will say about psilocybin, it was decriminalized in the city of Denver in 2019. It was fully legalized for medical use in Oregon in 2020, and they've actually just started this year opening up psilocybin-based treatment centers where you can go in Oregon. And then there are several cities in several other states that have either decriminalized it or deprioritized arresting people for possession and personal use. I mentioned ketamine is already legal, psilocybin probably within MDMA probably within the next few months to a year, and psilocybin will probably be the third one by the end of 2025. It's what it's looking like. It is considered the most researched substance. It's been looked at for a variety of treatments for different addictions, including conditions like anxiety, depression, PTSD, OCD, headaches, migraines, etc. Currently 150 different clinical trials happening, including at least 3 going on for major depression. Some of the interesting research I wanted to share with you on this: smoking cessation. One session of psilocybin, 80% of people were abstinent from smoking at 6 months, 67% lasted a year. Alcohol use. Recent study, 2023, published by actually Dr. Michael Bogenschutz, who used to be at UNM. We worked with him at LifeLink on a number of clinical trials in the past. He's since moved on to NYU, and they're looking at psilocybin as a treatment for that. Found among heavy drinkers, 26% had an overall decrease in amount of drinking and a 27% decrease in the number of days in a given month they drank. So very promising there. Major depression, 71% had a significant depression after a week, significant reduction in depression after a week, with just over half fully in remission about 3 months post-treatment. And the early psilocybin research at Johns Hopkins was looking at end-of-life mood disorder, people with fatal illnesses who were about to die, giving them the substance to see. And what they found is that about 80% had a clinically significant decrease in depression and anxiety post-treatment. Many of them reported it was the most powerful spiritual experience of their life. So a lot of different applications we're looking at. There's tons of research out there, but those are some of the more interesting ones. So I know we're running out of time very quickly. People think that the psychedelics work. We're not clear. We know some things about them, but in 2 ways: by changing both your brain in terms of chemistry and structure, and your perspective. So it does impact neurotransmitters, especially serotonin, as I said. The psychedelics do not seem to hijack the brain's reward centers like opioids. This is why it's not addictive. It doesn't tap so much into the dopamine response where people feel they need them. They don't build tolerance to them. So while people might enjoy doing them and want to do them a lot for partying, etc., there's not a physiological dependence that happens with them. But also what you start to see is that the brain just becomes more flexible, more plastic after a psychedelic. We call it neuroplasticity. We see increased connectivity in the brains that don't often talk to each other. This is a great slide looking at functional MRI studies in the brain. A normal person's brain, the different colors on the left are different brain areas and how much communication is going on. Under the influence of psilocybin, how much brain communication is going on. Areas of the brain are just talking to each other, chemicals are being fired, and in terms of learning theory, new associations are being made. A big idea, a big thing that's been popular the last couple decades is what's called the default mode network. It's a series of brain structures that involves what our brain is doing when we're not focusing on things. If you're just driving your car, sitting around, your brain kind of goes into what we call default mode. And what we see with a lot of different disorders like Alzheimer's, depression, PTSD, et cetera, is that changes in default mode are contributing to those diseases. So a very simplistic explanation is if you're someone who is depressed and you start to think in those ways that everything is bad and I'm never going to get better, et cetera, that actually becomes your default mode. Same thing with anxiety. If you're always worrying, that becomes your default mode. What the psychedelics do is allow you to kind of interrupt and break out of those rigid styles of thinking, feeling, behaving, and promotes flexibility, coping, and restores individual agency. You're no longer a victim to those negative thinking patterns, but rather the psychedelic helps the brain realize there are different ways of looking at all this. And so let's stop this whole thing. All right, next steps very quickly. We need to continue doing clinical trials and expanding them to look at safety, efficacy of the drugs. We need a better understanding of the therapeutic mechanism. It's great to talk about default mode, but we don't necessarily know that that's exactly what's going on. The deeper we can understand the receptors, the transmitters involved, the better we can target these things. We obviously need changes in drug legality, scheduling, the availability of medicine. Of course, if we're going to really use this in clinical settings, we need pharmaceutical companies making them. It's not going to be, oh, you have a therapy appointment next week, go find some mushrooms and come. We need to know that things are controlled. Public education, what we're doing tonight, and addressing stigma issues. Like I said, a lot of people I grew up 80s, just say no. drugs are bad. They put holes in your brain. They, change your DNA. Psychedelics don't do that. So we need to increase education around that, and then access and affordability. And this is a big one for me. You can get these treatments even now, even though psilocybin and MDMA are not legal. If you know where to go in Santa Fe, you can find people who will guide you through therapy sessions under the influence. Of course, the insurance isn't covering that. Very expensive. So if you're rich and can afford that, you can get that. However, if you are the typical client the LifeLink works with on Medicaid, limited resources, you can't get that. So I've already been working very hard with the state and managed care companies to say, you need to start covering this. If we can potentially cure someone in 3 months by just paying for a few sessions rather than putting them on a drug for the rest of their life and having them in treatment the rest of their life, it's worth the investment. But I'm especially committed to bringing this to, like I said, LifeLink's population. Because honestly, I believe that the people we work with, the homeless, the indigent, the dispossessed, they're the people who need these treatments the most, but they're the ones who it's least accessible for. So I am committed to bringing this to Santa Fe, to the LifeLink, as soon as legal methods allow me to do that. So finishing up here, I almost made it. Couple of great quotes, I think. We're depriving millions of people of a better life by not making use of what has been known throughout history. These are tools to heal, to treat, to get to another level. It's not like we're going to wave a magic psychedelic wand and solve all of our problems, but it's a very important tool to have in the toolkit. Interestingly, that's Dr. Bronner of Dr. Bronner soap and lotion and all that. He's a huge contributor to psychedelic research. And then finally, in terms of shifting to a new paradigm in the healthcare system, I think the key shift needs to be one from a system that is focused on managing disease and managing disease symptoms, which is what we currently have, toward a symptom focused on producing well-being. And I think psychedelics have a big role to play in that type of system. I can't say it any better than that. So with that, thank you for tolerating the snafus along the way and your interest in this topic. Here's my contact information. Please feel free to reach out to me, and I'm certainly happy to take any questions or comments that anyone has at this point.
All right. Well, thank you so much, Michael. That was just a wonderful overview of the topic. I certainly learned a lot from it, and I've been studying this particular topic for quite a while. If you do, and again, we're going to go till 7:15. If you need to leave now or anytime between now and 7:15, feel free to. I just wanted to start off by sharing a personal testimonial, if you will. I struggle with depression. I have struggled with depression for the last 30 years, on and off. A number of years ago, I was pretty much diagnosed with what's called treatment-resistant depression. I had tried, probably 8 or 9 of what are called the selective serotonin reuptake inhibitors that started off with Prozac for me about 30 years ago. And I went through a whole bunch of them and sometimes found some relief from them, and over time found that they really didn't help me. And a couple of years ago, when my depression flared up after my mother passed away here in town, I did try ketamine and actually sought Michael's counsel on what the experience was going to be like. And so I went to one of the clinics here in town and did intravenous ketamine. And I had 5 sessions over the course of about 2 months. It was a very intense experience. The journey under ketamine was very intense, but generally pleasant. I found it to be significantly helpful for me in reducing my depression. Didn't make it totally go away, but I'd say it went from being a 6 or 7, my depression on a 10 scale, down to a 2 or 3, much more manageable. And I had severe, what's called anhedonia. Anhedonia is basically, comes from the word, or the root word, of hedonism or pleasure. It's when some of us that deal with depression can experience joy or pleasure from things that normally give us joy and pleasure. And my whole ketamine sessions significantly got rid of my anhedonia. And so I just wanted to share that with you, that I'm just one person, I'm not a clinical trial, but I did find it quite helpful. And I did a booster session a year ago, February, of IV ketamine, and found it to be helpful as well. So with that, I don't see anybody's, or do we have a question? Oh, Cam has a question. in the chat. Have any psychedelics been determined to be less effective or more harmful? LSD was studied early on and hasn't made the top 3 list so far. My curiosity is whether some drugs are more effective than others, or whether simply the psychedelic experience is the healing process, regardless of the vehicle. Good question, Cam. Michael?
Yeah, great question, Cam. Thank you. This is why we're doing the clinical trials, because some substances seem to work better for some diseases, some disorders than others. So there are clinical trials going on for depression, for instance, right now for psilocybin, MDMA, DMT/ayahuasca, and LSD. And we're going to find out which ones are working the best or not. Yeah, LSD was studied early on, and there were some really incredible results then. I would say probably it's not top 3 right now, but I would say it's top 4. One of the challenges with LSD is how long the trip lasts. It's a 12 to 14-hour trip for many people. And in terms of clinical utility, it's really hard to spend 12 to 14 hours with someone and to pay for 2 clinicians to be in a room for that long of time. Even psilocybin, 6 to 8 hours, I'm sorry, MDMA, 6 to 8 hours, psilocybin, 4 to 6. So I really think that's the reason why LSD is not being studied as much, just because it's really hard to devote that kind of time to it. But the results for LSD for a variety of addiction disorders, OCD, etc., are showing that it's very powerful. I think your last point there is really strong, that it seems to really be more the experience of the psychedelic that is what heals, as well as the therapy that goes on around it versus the drug itself. In the MDMA training I went through, what that talks about is, and I like it because it fits in with a lot of other different healing models in the world. It says that we all have an inner healer inside of us that wants to heal us, that wants us to get better. And what the drugs do is allow us to get into a space where we can be empathic toward that healer, welcome that healer, and allow it to do its job. So if we look at it that way, the drug is just what's getting us there. It's what we do with the experience that makes the difference for us.
Yeah. Thank you for that, Michael. And there's a question that I can pretty much field from Susan Hagen. I apologize if I butchered your last name, Susan. Will we have access to the PowerPoint? I do want to make clear that this whole presentation has been recorded, and it will be on our YouTube, on the YouTube website under NAMI Santa Fe, probably by the end of the week, Jessica, something like that. However, I understand some people would rather just have the PowerPoint. Michael, we have your PowerPoint. Is it okay if we posted it on our NAMI Santa Fe website? Are you okay with that?
Sure.
Great. And I have a question for you, Michael. You and I spoke about this on the phone. You had mentioned that the New Mexico legislature, this legislative session had adopted or passed some sort of resolution about studying psychedelics or something like that. Could you let us know about that?
Yeah, this last year, there is a group, the New Mexico Psychedelics Society, that's really, a group of professionals, healers, indigenous folks, lay people, et cetera, who are really pushing toward this. And they've been doing some strong lobbying. And yeah, this year the legislature passed a resolution to have Department of Health look into the potential of these substances for treatment. It's a very first step. I would say they should have just attended my presentation. That should have given them what they needed. But they need to do their study, so they can do that. And then the next step would be looking at it. States across the country, things are in all different levels. Like I mentioned, Oregon, you can go to a mushroom treatment clinic right now. Different states have different things going on. I will say, though, with New Mexico, interesting little thing in the law, psilocybin mushrooms are perfectly legal to grow and possess, and even to give to other people. You can't sell them to other people, you can give them to other people, but they're illegal to ingest. So make of that what you will, but there are plenty of people I know growing and sharing mushrooms around. Just don't be around a cop if you're taking them, I guess. But of course, that's recreational use. When we're talking about clinical use, it should be under those kind of guidelines.
Important clarification. David Chamberlain has a question. Take it away, David.
Yes, the phone number for Michael went by too fast. Can that phone number be repeated?
Sure. 505 395 2532.
2532. Thank you. I
Sure.
have a son who's bipolar, and it sounds like none of these things are specific to bipolar. They're much more for depression and PTSD. Did I hear correctly?
That is correct. And I did mention on the one slide, usually bipolar disorder would not be allowed into a clinical trial because what it looks like with some people with bipolar, the psychedelic can create a manic reaction, a manic phase. I
Okay.
will say, though, it's the same thing with all of our antidepressants. They're contraindicated often for people with bipolar disorder because they can create a manic phase. So, um, you know, once things are legal and there's a little more research done, we may have an idea. But at this point, um, at least looking through legal channels, I'm not sure that there would be anyone who would work with or advocate, for your son to take that approach to it.
Thank you.
Thank you, Michael. Looks like Susan's got a question, and Robert will take Susan first. Unmute yourself, Susan, and ask your question.
Yeah, hi. I joined late. I was wondering if you addressed ayahuasca.
I did not address ayahuasca. It's very powerful. It's got a lot of good research behind it, but I only specifically addressed the three substances that are closest to legalization and have the most clinical trials behind them.
Okay.
Ayahuasca is being used all over the world by lots of people, really promising results across a wide range of disorders, but it's not yet to the point of, I don't even think there's a phase 2 clinical trial for ayahuasca yet, but it's coming.
Right. Well, I have real mixed feelings about it just because it's going from its traditional places and the people who are providing that to, to the general public, and that just feels odd to me. Feels I'm not comfortable with that at this point yet. So
Great point for sure. With all of these substances, there are people using them out of context. We certainly need to appreciate the indigenous roots of many of them and try to root the healing around that. And so, yeah, that's why until these things are legal and controlled and there are studied protocols, I'm not recommending people play around with it.
Thank you. Thank you for that, Susan. Robert, please unmute yourself and ask your question.
Thank you very much. I apologize. I'm having some issues with my camera. But I just wanted to ask if you could explain a little bit more, Dr. DeBernardi, just about in a clinic or in a treatment sense, the openness or the use of these drugs in a clinical or treatment plan sense, and the openness that it could bring to the clients and their treatment.
Well, the clinical protocols are trying to remove this from a clinical setting. I know if you go to a lot of the ketamine clinics, you're literally in kind of a medical chair and they're hooking you up, et cetera. But with the MDMA and the psilocybin research, they're trying to make it very much a homey kind of environment, not clinic setting, very comfortable, beds to lie on, art books to look at, art supplies to work with. Music is a huge part of it. So much of this research is finding that music deepens the experience of the substance. In fact, if you're on Spotify or whatever, just look up music for psychedelic therapy. You'll find all of these playlists that people have put together, very specific to, and in fact, MAPS, that is, kind of written the book on this, they've got very specific protocols. The music starts out very rhythmic, very, exciting to kind of get you into it. It moves into a much more kind of emotive type soundtrack music, that kind of thing. And then it comes out kind of more ambient, regrounding kind of music. So the protocols have been designed to make it as open and welcoming, et cetera. And, I showed in the slide about the protocols, someone's not going in. So the same therapist who is in them during the medicine session is the ones who have done all of the other preparation, the integration sessions, etc. So the idea is that the therapeutic rapport has been built with the clinicians in the room before the medicine session, so that it's not just like a stranger, who is this person, and the relationship, as in all therapy models, helps with the healing process. Not sure that answered your question, Robert.
It did. Yes. Thank you. Thank you so much.
Yeah, sure. Thank you, Robert and Michael. Michael, you probably will be able to answer this, but you may not. So as you know, the ketamine, because it's allowed by the FDA to be used, but off-label, is not covered by insurance. It was rather expensive for me to pay for those sessions, although I was very grateful that I was able to. With MDMA possibly being legalized and recognized as a behavioral health treatment later this year, and maybe psilocybin a year later, does that mean insurance is pretty much going to have to cover it?
Have to is a good question. I have talked to some of these managed care executives and made my case that you need to do this. And generally the response I've got is, oh, we're not ready to go there yet. Come back and talk to us when it is legal. But there are certain currently legal psychiatric drugs that insurance companies won't cover because they're too expensive or they're too new. So I probably see that happening early on, as them just not being willing to cover it or cover 50% or whatever. And let me add with that, the cost of doing this work is expensive. Looking back at that slide where we talked about all of those 90-minute sessions, and then the therapy session itself being 8 hours long, you're talking about paying for 2 therapists in a room for 8 hours. That gets very expensive very quickly. So we're going to have to work this out. Again, to me, it's a no-brainer. If you can pay for 4 months of expensive treatment that could last a person a lifetime, it's worth the cost to do that. But those are the arguments that are going to have to be made with managed care. The fact that the state is studying it makes it hopeful, because even though it doesn't always work like we hope it does, theoretically, the state tells the managed care companies what they need to cover under Medicaid services. So if the state gets on board and says this is useful, hopefully at some point they can tell the managed care companies, you're going to pay for this regardless of how expensive it is. That's the hope.
Great. Thank you, Michael. I'm not seeing any more questions. And so with that, I think we'll wrap the evening up. Again, on behalf of the NAMI Santa Fe board, I'd like to thank you, Michael, for presenting a really fascinating talk, very comprehensive and thorough. And I personally found it very interesting. I hope the rest of you audience members did as well.